Um, all right, so my objectives for today, I'm gonna try not to dry heave. I'm gonna talk about spouses killing each other with poison. We're gonna go on some tangents, and then while I have you all captive, we're gonna look at pictures of my dog Baby in co-residence. Disclaimers are important. I don't endorse or support the harm, poisoning, murder of spouses or significant others, okay? It's very important to note that. This is my wife. She was very interested in this talk for unclear reasons to me. I was like really interested. All right, so we're gonna get started. So case one, the year was 2018. Steve and Lana Clayton had been married for 5 years and lived in a beautiful home in sunny South Carolina. One fine morning, Lana came running out of the house, screaming for help. Eventually, police were called to the scene. Steve was found dead at the bottom of the stairs. Initially ruled as a possible heart attack by the coroner's office, there were some suspicious circumstances surrounding Lana's behavior. Specifically, Lana wanted the body cremated as soon as possible when Steve had made it clear that he wanted to be buried in a cemetery with his family. Additionally, Steve was out of contact for 3 days prior to his death, was without his cell phone, and his family was concerned. He always had his cell phone on him. When family finally was allowed to see the bedroom, they found the bedroom in complete disarray. Apparently, Steve had been laying in bed, urinating in the sheets for 3 days. And Lana was very quick to tell everyone it was just about a vertigo. We don't have much information about about Steve's clinical presentation prior to his demise, but if I told you that he had pinpoint pupils, respiratory depression, was somnolent, bradycardic, and hypotensive, well, what kind of thoughts might run through your head in terms of possible exposures? Yeah, opioids, right? It sounds like an opioid overdose. Well, to everyone's surprise, at the family's request, full toxicology and autopsy was performed. And what they found was dangerously high levels of tetrahydrolazine in Steve's body. When Lana was confronted with this, she said that she broke down and eventually said that she had been dosing Steve's water and food with Visine drops, and eventually had given him just a big squirt in his water one day. And so Lana was eventually sentenced to prison for murder. So mystery solved, right? Tetrahydrolazine. Which brings us to an interesting topic. So tetrahydrolazine, if you're not familiar with it, is in a family of compounds which are known as imidazolines. And you can see up here a couple of familiar examples: clonidine and dexmedetomidine we use quite frequently and are also related compounds. They all share this heterocyclic 5-member ring. To talk about the mechanism of action of tetrahydrolazine, you have to get a little bit into the baroreceptor reflex. And so we have here the anatomic pathway of the baroreceptor reflex, as well as kind of the reflex arc on the right. The kind of most important things I want to point your attention to is where the reflex terminates. And so where the efferents of the baroreceptor reflex come off is this area of the brain in the medulla called the rostroventral lateral medulla. And this is like your sympathetic center. As everyone can read, when you have decreased stretch on the carotid sinus receptors, this causes increased firing rate of the carotid sinus nerve, which then reduces your parasympathetic outflow, increases your sympathetic tone, restoring your blood pressure. And so what the RVLM does there is it modulates the sympathetic and parasympathetic tones. When we think of imidazolines and clonidine as like our prototypical imidazoline, we know that they're alpha-2 agonists. We think of that as being their primary mode of action, right? And being responsible for all of the effects of clonidine and other imidazolines, the dry mouth, the sedation, as well as the hypotension. But the story is actually a little more complex. And this is something I had only learned about by reading about this topic, but it turns out that clonidine actually works and other imidazolines work at specific imidazoline receptors named very, very creatively for the compounds that activate them. And imidazoline receptors, they're upstream of the alpha-2 receptor. They have a number of different effects in the body. Clonidine and other imidazoline receptors, they also, of course, act at alpha-2 receptors. Other medications have been formulated which are specific imidazoline receptors and have much less activity at alpha-2 receptors like moxonidine. You can read it, it's right there. And the interesting thing about these imidazoline specific agonists is they actually have less sedation, less respiratory depression, and they have less of that rebound hypertension we see with medications like clonidine. So as I said, the imidazoline receptors, they're present throughout the body. Imidazoline 1 receptors are located in the CNS. They're in the RVLM, as we discussed, at the sympathetic center, and they modulate, they basically control sympathetic outflow. Imidazoline 2 receptors seem to play a role in like anti-nociceptive pathways and increase your endogenous opioid signaling system. And imidazoline 3 receptors are located in the pancreas, and they play a role in facilitating insulin secretion. So really widespread receptor system that I really would only encountered reading about clonidine and tetrahydrolazine. So tetrahydrolazine specifically, there are actually quite a few cases of tetrahydrolazine poisoning in the literature, and a lot of them are in pediatric patients just because Visine is everywhere and it's easy for a child to pick it up and take a couple of drops orally. It's very rapidly absorbed by the PO route with an onset about 1 hour. It's actually also been used in a number of cases of drug-facilitated sexual assault and robbery. And the reason being is it's not only is it pretty rapid in onset, but it's also tasteless, colorless, and odorless, making it very easy to slip into someone's drink. Symptoms are basically an exaggerated agonism at alpha-2 and imidazoline receptors, and it looks an awful lot like an opioid overdose. So you get somnolence, bradycardia, hypotension, respiratory depression, and meiosis as well. In terms of management, naloxone is the antidote of choice. It's likely that naloxone use probably originated from the similar toxidromes that we see with imidazoline overdoses and opioid overdoses, as we noted all those similar features. There's also, interestingly, a lot of crosstalk between the alpha-2 receptor system and the opioid signaling cascade. And so the thought is that basically what you're doing with naloxone is you're blocking endogenous opioids and allowing the balance of sympathetics to kind of outweigh all of the parasympathetic and endogenous opioid signaling system. Reversal of sedation might not be seen unless with very high doses, sometimes 6 to 10 milligrams of naloxone. And there's really no contraindication to giving that high a dose as long as your patient is not chronically taking opioids and you're concerned you might throw them into withdrawal. Kind of begs the question though, why don't we use alpha-2 antagonists? They exist, we have them. Yohimbine, atipamezole, and tolazoline. So they're not standard of care, although there are case reports in the pediatric literature of them being used for clonidine overdose. Reason being is that these actually tend to have pretty nasty side effect profiles, namely like tachycardia, hypertension, and ventricular arrhythmias. So for those reasons, they're not used, and we favor naloxone. They're used pretty extensively in veterinary medicine, both when working with dogs and deer to reverse xylaxine, which is a alpha-2 agonist that they use in veterinary medicine and the Department of Forestry. There's some groups that argue that atipamezole specifically should be made available, especially for vets and wildlife workers who work with, say, like elephants, because they use highly concentrated doses of alpha-2 agonists to take down these animals. And atipamezole actually does have some decent human safety and efficacy data. Interestingly, the converse, using clonidine as an antidote for, say, a yohimbine overdose, which is seen in some performance athletes and bodybuilders, that actually does seem to be a pretty good strategy. So talking about Visine, it kind of made me think about eye drops in general. And so, you know, we don't think about eye drops a lot when we're talking to patients about what medications they're on, when we're kind of trying to put their clinical picture together. But most topical ophthalmic drops, almost 80% of the medication is actually absorbed systemically. Additionally, you're bypassing first pass metabolism when you instill a drop into the eye. So specifically timolol as an example, a 0.5%, a single drop of 0.5% timolol ophthalmic application, it's equivalent to 10 milligrams via the PO route. So it's a significant exposure. And there's this paper, this is a 2015 paper, where they found a significant increased risk of hospitalization for bradycardia in patients taking timolol. Specifically, it was like after 30 days of starting the timolol and didn't go past 180 days. But so something to be aware of when you see a bradycardic patient and you haven't identified an etiology yet, is consider ophthalmic meds. So some reflections from this case in particular. Think about eye drops, and definitely try naloxone for imidazoline toxicity and overdoses. But remember, you might have to go pretty high on the dose. Case 2. This case comes to us from West London, 2009. This strapping young gentleman, Lakhvinder Chima, known as Lucky to his friends, had engaged in an affair with Lakhvir Kaur Singh, this woman over here, for 16 years since the failure of his first marriage. Lucky broke off the affair and became engaged to a younger woman, Gurjeet Chung, over here on the left. And that is where our story begins. One fateful night, Miss Singh was seen entering and exiting the apartment of the to-be-wedded couple. Some basically neighbors saw her leaving. They thought it was suspicious, but they didn't think much else of it. Lucky and Gurjeet shared some leftover chicken curry that they had, and Lucky actually had a second helping. It was so delicious. But afterwards, both rapidly developed oral paresthesias. That's why I can't feel my face by the weekend. Persistent vomiting, and Lucky actually went on to develop some blurred vision, prompting them to call a family member to take them to the hospital. By the time they arrived at the hospital, Lucky was complaining of total body paralysis and immobility, and he actually died just an hour after his arrival to the hospital. Gurjeet, having only consumed one helping, actually survived after like a 2-week hospital stay. Given the symptoms they experienced, perioral numbness, tingling, facial numbness, paralysis, as well as the vomiting, does anyone want to offer some possible thoughts as to what could have been in the diabolical curry? That's a great guess. Chrissy said tetrodotoxin. Love that guess. We'll just move on because no one's going to come up with a better guess, guys. Come on. Well, it turns out that Miss Singh, who is subsequently and at this point known as the curry killer, had recently traveled to India and procured a poison which she sprinkled on the couple's curry. And this poison was Indian aconite. Aconite's also known as monkshood and wolfsbane. So just like the coolest names for like a single plant. What's interesting about this case is that it's actually the first case, 2009. This is the first case of prosecution for murdering by aconite since 1882. Aconite has a really interesting pharmacology. It's a sodium channel opener. And so I have a riddle for you. So we're very comfortable with the idea that sodium channel blockade prolongs the QRS. So, but what happens when you have a sodium channel opener? What does that do to the QRS? Yeah, okay, good. I don't have a slide that shows that, but basically it makes it wider. No, we're gonna get into it. I'm sorry, everybody. So this slide, while terrifying at first glance, is actually not so horrifying. So what happens with the sodium channel sustained opening is you have prolongation of depolarization. With prolongation of depolarization, calcium channels continue to open and close. And so what happens is calcium continues to flood into the cell. Cell tries to maintain the intracellular calcium at not a very high concentration. So what it does is it sequesters the calcium into the sarcoplasmic reticulum, and it also reverses the sodium calcium exchanger. That is to try to get sodium out of the cell, but in effect continues to pour calcium back into the cell. And so basically what you get is calcium coming into the cell, overloading of the sarcoplasmic reticulum with calcium so that further depolarizations continue to spill calcium intracellularly. Basically what this leads to is both early and late after depolarizations, where the cell is held in a relative refractory period, and these fluxes of calcium cause it to continuously depolarize. You see different effects on the cell in which this is occurring. So what I mean by that is this pathologic process occurring in the myocardium is what gives rise to ventricular arrhythmias, excitability. But this same pathologic process happening in, say, the baroreceptor cells causes increased vagal tone because the vagus nerve becomes hyperexcitable. And so you get bradycardias, asystole, AV blocks, and all those GI symptoms that we associate with not just sodium channel opening toxicity, but also toxicity like with DIG. What's interesting about aconite poisoning is it's one of those toxins that also can cause bidirectional VTAC. So we think of this as being pathognomonic for a digoxin toxicity, but there are a couple other things that can cause it. In terms of management for aconitine poisoning, there's no real specific antidote, so it's going to be largely supportive care. Yes. For Brady dysrhythmias, atropine is still recommended. In terms of treating ventricular tachydysrhythmias, these tend to be pretty resistant to electrical cardioversion. And there's some data that amiodarone might have decent efficacy. There's some case series that have looked at which antiarrhythmics might have the best efficacy. Amiodarone seems to be one of those. It's thought that maybe the reason is amiodarone has many other effects in addition to its class 3 antiarrhythmic properties. It also has calcium channel blocking effects, and it's thought that the underlying pathophysiology being this sustained influx of calcium into the cell, that might be why amiodarone seems to be more effective than other antiarrhythmics. Flecainide also seems to perform pretty well. But ultimately, refractory hypotension and persistent ventricular tachycardias might warrant cardiopulmonary bypass or ECMO as like a bridge to metabolism. That's it. Those are the two cases I wanted to present. Now you get to look at pictures, or not get to, but are forced to.